Good morning. Just to go quickly to the crunch of our debate, we immediately start the panel discussion, and we are going to invite our guest, a foreign guest that helped us in the study of this disorder. It is a great honor and a great pleasure for us to have them with us, because this is quite a difficult disorder in terms of treatment and in terms of diagnosis. And we have to recognize that we need to be good pediatricians in order to diagnose and treat our children well, before having to refer them to neuropsychiatrists. The first speaker will be that of Professor Swedo, who is our hero and a pioneer in these studies. Dr. Swedo is a fantastic pediatrician. She works at Bethesda, and she's the doctor that, with a great deal of simplicity and humbleness, she agreed to share with us her cases. The floor.
Hard enough for me to talk in English, but we will go very quickly. And the first speaker was wonderful. She gave you a great overview of what we will talk about today. I have no conflicts of interest to declare. It is very important when we think about pandas and the larger group of patients with PANS to remember that they are but a fraction of those children who have obsessive-compulsive disorder and tic disorders. I've had the privilege so far of meeting many moms here in Italy, and I am very reassured that they and the doctors here are doing a great job of making the diagnosis and not including children who have regular OCD in the PANDAS group. The reason this is important is because there is such a difference in the way the children should be treated. And if we include kids who have not got PANDAS and give them immunomodulatory therapy, they will not get better, and you may have done them harm. So we will talk a lot today. You have 2 sessions on diagnosis, and the reason for that is it is so important, and it is just a clinical distinction. So as you've already heard, the PANDAS subgroup was first described in the late 90s, but we actually started looking for it in the mid-1980s. It became extremely controversial, at least in the United States, to the point where Dr. Trifoletti and Dr. Kovacevic and Dr. Latimer were probably the only 3 doctors in the United States who were willing to treat PANDAS patients outside the National Institutes of Mental Health. This was a problem because it's not a rare disorder. There are hundreds, if not thousands, of children affected every year, and many of them will get better on their own because the infection goes away, the antibodies go away, and they get better, just as you do with Sydenham chorea, but many of them do not. And it is those children that we were working hard to make sure would have some relief. For that reason, we described the PANS. But as you've already heard, the neurologists, the one who had been so anti-PANDAS to begin with, coined their own term CANS. And it was done very specifically to slap us in the face. They were not wanting anything to do with PANDAS. They didn't believe it existed. Let's set that aside and recognize, as you already saw, the very close similarities in the diagnosis of CANS and PANS, and that is that it has to have an abrupt onset. You heard the word foudroyant from the French for lightning-like, and the children are truly struck down by their illness. In PANS, as in CANS, tics has taken a secondary position. You have to have obsessive-compulsive disorder. And I suspect that you would never see a child with a Pandas presentation of tics who did not also have some kind of OCD, particularly with the separation difficulties. So you have OCD plus tics or choreiform movements, separation anxiety, the emotional ability. We argue among ourselves how that's best described, but I can tell you that parents tell me that what they see is a complete and total change in their child's personality. They go from an easy, loving 5 or 6-year-old into this monster. One of the moms told me it was like her child was possessed. Another mom said it's like she became a teenager overnight. And if you think about the kind of issues that teenagers are dealing with, that's definitely what comes on to a Pandas child, but it's, again, overnight. They should be able to tell us exactly the day, if not the hour, that the symptoms started. Just as your children can tell you when they get an otitis media, when they get an ear infection, the pain is very acute, it's very abrupt, and it's very different than what they've been experiencing previously. They have behavioral regressions. They may start talking baby talk, even though they're 8, 10, 12 years old. That you see from, those are actually Dr. Kovacevic's drawings from one of the patients in his practice, and you can see that the child loses skills. And probably the most telling is the presence of urinary frequency, urgency, or new onset of daytime accidents or nighttime enuresis. If a child presents with behavioral changes and urinary symptoms, you have to think about Pandas. Academic difficulties, again, not only do they become a teenager overnight, but they develop ADHD overnight, attention deficit hyperactivity disorder, and the children cannot concentrate, they cannot remember things, and they develop acute onset of visual spatial skills and executive dysfunction, and I'll show you a slide of those in a moment. And then finally, the motoric or sensory abnormalities. You have to have at least 2 out of 7 of these symptoms in order to have Pandas or PANS. All of the children that Dr. Kovacevic and Dr. Latteram and I, when we combined our clinical practices and looked at the children, they had 4 or 5 or 6. The mean number of symptom categories was 4. So it is not hard for them to meet the diagnosis of PANS. Well, let's get back to Pandas, because that's the one that we've studied the most at the NIH, and that we actually have some very lovely scientific data documenting not only that this illness is real and can be distinguished from OCD, but that there is a hypothesized and now proven etiology through group A strep. The context for the discovery was that in the 1980s, clinicians considered obsessive-compulsive disorder to be the classic form of anxiety disorder and thought that it was caused by, of course, the mothers. The moms had punitive toilet training practices or harsh parenting, and that was what gave you OCD. Freud himself had defined OCD as very separate from this model of neurosis, but that had gotten lost in the ensuing decades, and parents were being blamed for their children's symptoms. Dr. Judy Rappaport, who was my boss at the NIH, and Dr. Michael Rutter in London were among the pioneers who believed that OCD was a brain-based biological or medical illness, and they were looking for models within other disease families. We looked at Sagawa's dystonia and Huntington's chorea and many other neurologic illnesses and settled on Sydenham chorea as the best example. I promise you this is the only time you're going to have to look at hard science, but we do need to understand the circuitry within the brain, which is the orbital frontal cortex, through, in animals, the striatum. In humans, it's called the basal ganglia. It's exactly the same area of the brain. It's a very old region whose job it is to be a gatekeeper, to decide what's going to go forward and what's going to be inhibited. You can imagine that if that's not working well, then loops get set up and things repeat over and over and over again. In obsessive-compulsive disorder, the primary site of dysfunction is the orbital frontal cortex in adults and the caudate nucleus, part of the basal ganglia in children. In tic disorders, it's the putamen, which is another structure within the basal ganglia. And then to pull in the ADHD symptoms, the attention deficit symptoms, you just have to go to the globus pallidus externa. They're all controlled by different neurochemicals, serotonin for OCD, dopamine for tics, and norepinephrine for ADHD, and yet they all have a common area of anatomic localization. Then that model continues back through the globus pallidus interna and the substantia nigra to the thalamus, which we have shown it can be involved in Pandas patients, to the orbital frontal cortex. And I just went the wrong way. So within that loop, you can have different areas of dysfunction. They can result in the same kind of symptoms or actually very different symptoms. The reason this is tremendously important is because we already knew from studies in adults with obsessive compulsive disorder that this loop was dysfunctional. And from primate studies, we learned what its job was. So Sydenham-Chorea, if we go back to this loop, Sydenham's has very clearly documented pathology in both the caudate and the putamen within the basal ganglia, so right where it needed to be in order to have OCD. Sorry, I'm talking too loud. The Sydenham-Chorea is the neurologic manifestation of acute rheumatic fever. Unlike rheumatic heart disease, there's a variable length of time between the inciting strep infection and the onset of symptoms in Sydenham-Chorea. Important to notice that up to 2/3 of patients with Sydenham's do not have rheumatic heart disease, and this is important because neither do Pandas patients. In fact, you should look for rheumatic heart disease in any patient presenting with severe OCD, severe Pandas picture, to make sure that they don't fulfill the criteria, Jones criteria for rheumatic fever. ARF is always accepted as a post-strep illness, largely on the basis of circumstantial evidence collected in the 50s and 60s. The etiologic mechanism is unknown, but you're going to hear more about it from Dr. Cunningham in a little bit. It's thought to be related to molecular mimicry. And the best working model is that certain strains of group A strep in genetically vulnerable host, about 1 in 20 families is susceptible to rheumatic fever, so we suspect the same is true for Pandas, gives rise to a misdirected immune response that looks like it's autoimmune, but it's not. It's actually just antibodies that have been made against the strep that get mixed up and attack the basal ganglia. And that gives rise to a variety of symptoms. The process of molecular mimicry is important. There's some debate and dissension about that as well, but I think Dr. Cunningham, Dr. Orifici's work, and those of other investigators has nicely shown that the strep bacteria survives by putting proteins, sugars, and fats on its cell wall that look just like its human host. Well, not just like its human host, almost like its human host. And that slight difference is what the key is, because it sets up this immune response. In Sydenham-Chorea, you have post-strep autoimmune encephalopathy that is documented on the presence of chorioathetoid movements, and you're going to have a talk on that this afternoon, so I'm not going to go into a lot of detail on that today. However, the relationship of Sydenham-Chorea to obsessive-compulsive disorder actually dates to the very earliest descriptions. You've already heard about Osler's observations. Sir Thomas Sydenham, after whom the disease is named, also talked about perseverativeness of behavior in these children. In the 50s and 60s, there were a number of retrospective studies as well as some prospective studies examining this relationship, and what they found, just as we saw at the NIMH, was that children with Sydenham-Chorea had an abrupt onset of obsessions, bad thoughts, and compulsions, repetitive rituals, 2 to 4 weeks before their movements began. Not a psychological response to the disability they were receiving from the motor dysfunction, but instead perhaps a form fruste of Sydenham-Chorea. And form fruste just means that it didn't fully develop, but it actually pathologically is quite interesting because it may mean that there's a difference in dose, a difference in presentation of those antigens, or actually a difference in the antigen complement that gives rise to the OCD. With these observations in patients with Sydenham chorea, we looked at the 125 children who were participating in drug treatment trials at the NIH and found out that 1/4 of them actually had had an abrupt symptom onset, a history of an episodic course that was relapsing and remitting, and they had the presence of choreiform movements, fine piano-playing movements present on stress neurologic exam. That onset and the relapsing and remitting course distinguished them from what we call garden variety OCD, or the larger class of children in whom symptoms begin gradually. They hide them for a very long period of time until they become too much, and then their parents might find out, but then they hide them even longer till their friends at school find out. And it takes weeks or even months for the symptoms to develop to the point where they're impaired. In pandas, that same level of disability comes on within 24 to 48 hours. The children were also quite young, and boys outnumbered girls in our sample by about 2 to 1, just as they do for tic disorders, but more importantly, in very large distinction from a more classical form of OCD in which females predominate over males. The criteria for pandas were developed as research criteria, and that's the reason that we required an episodic course. We required at least 2 episodes that had been triggered by strep, but we knew from Dr. Orefice's work and others that any time you've had a sensitization from a strep, you can then have recurrences as a result of a viral infection, an other bacterial infection, or any immune trigger. So even psychosocial stressors could trigger the exacerbation. And you need to remember that, because I've heard about children not receiving a diagnosis of pandas because they present in their 2nd episode or their 3rd episode and it's been triggered by a virus. You need to go back to that early history and find out if a sibling had strep at the time that the child initially presented with symptoms. I told you I couldn't talk in English. Pre-pubertal onset was drawn from Vince Fischetti's work, showing that children by the age of 12 have a 98% chance of having antibodies against the conserved portion of the strep. And what that means for you is that they are immune to strep infections. And so it can occur in adolescence or young adulthood, but it's much less common. The association with neurologic abnormalities, we've talked about the choreiform movements. That's probably your best sign. 95% of the children have them present during acute illness and less than 50% during convalescence, so you can use it as a bit of a marker of their course, and the temporal relationship between the symptom exacerbations and strep. I told you that the onset can have a lag, as it does in Sydenham chorea, but subsequent exacerbations, and even some of our children at initial onset, you check that throat culture and it's positive. And as you'll see in a minute, if you treat the throat culture, you can actually treat their neuropsychiatric symptoms. They had significant comorbid psychiatric symptoms, and this turned out to be the clinical feature that defines pandas as well as PANS, is the fact that these children have multiple comorbidities. At the top of the list here is sleep disorders. Children who had previously been able to go to sleep within 5 or 10 minutes of going to bed at nighttime, now taking several hours, and because of their separation anxiety, the mom or the dad has to lie down with them, rub their back, and try and get them to sleep, which seems to be impossible for both of them. Here, highlighted in pink, is eating disorders, and in Dr. Kovacevic's practice, you'll hear that he has even more than 20%. We actually, in our most recent cohort of PANDAS patients, had 40% of the children with an acute onset of eating restrictions. So this is, again, something that's quite unique to this group of patients and can help you make the diagnosis. Recent findings from our group done by Dr. Ashura Buckley document abnormalities of electroencephalography, specifically the presence of spike, sharp, and wave epileptiform abnormalities, or non-specific diffuse or focal slowing in 7 of the 42 children who were part of our most recent IVIG trial. That's about 17%, so it's not extraordinarily common, but it is tremendously important because the EEG abnormalities in the presence of the neuropsychiatric symptoms means you can assign a diagnosis of autoimmune encephalitis, and therefore the child can be treated under those protocols. Similarly, they had abnormalities on polysomnography. We only have the last 12 children from the series, and what's significant about this finding is the frequency, in the fact that 8 of the 12 children had abnormalities on their polysomnography. Now, all 12 children, so if you took the percentage of 80% of the children will have sleep abnormalities, we're within that 80%. And we don't know if children who don't have sleep complaints will also have abnormalities on their PSG. But these children had non-REM parasomnias. REM sleep is rapid eye movement sleep. They had periodic limb movements of sleep, as you might see in ADHD, but they had not had them previously. And most significant was the presence of REM behavior disorder, in which the children failed to establish neurologic atony, or a paralysis, during REM sleep. For those of you who don't know, during REM sleep, that's when you dream and your eyes move very quickly, almost like they're following the dream, but everything else is paralyzed, so you can't act it out. A REM behavior disorder, you're not paralyzed, and the children can wake themselves up straight out of those dreams and will report a history of severe new nightmares. Well, as I've told you, if you have the EEG abnormalities, you meet clinical criteria for autoimmune encephalitis. And AE is defined by the acute or semi-acute onset of psychiatric and neurologic symptoms, particularly seizures. In most of the hospitalized patients, seizures are present in 60% of the case series. The presenting symptoms, however, can be quite varied and may or may not be related to the antibody types that are thought to be, again, having that molecular mimicry. Evidence of neuroinflammation comes from the EEG, polysomnography, from MRI scans that show either focal abnormalities on the T2 weighted images, PET studies, we'll talk more in a minute about those in pandas, or CSF, which shows the presence of the antineuronal antibodies. In pandas, we've just finished looking at CSF samples in 45 children who were acutely ill. We found non-pandas antibodies, such as the anti-potassium channel, anti-calcium channel, in 5 of them. So it's very, very rare, and we didn't think that they were pathologic because they didn't have the symptoms that fit those syndromes. I think it's more cross-reactivity. Well, we borrowed the model of idiopathogenesis that had been used for Sydenham, Korea, to study pandas. And over the past decade, we've been able to establish that particularly the group A strep is playing a role, and the panda's name, although it's a bit silly, was well deserved in that these illnesses are definitely associated with, if not caused by, group A strep. There are 5 lines of evidence, the first of which is clinical observations and epidemiologic studies. In Northern Virginia, we went into an elementary school and observed children in the classroom for a school year from September through March or April. Sorry, it's November through June. Should look at my own slides. And what you see is that tics and problem behaviors are actually quite common, with about 10% of the children having tics. They're in the purple. And on the maroon or burgundy line are the problem behaviors, either getting up out of their seat without permission, interrupting the teacher, pushing other children in line, and those adventitious presence of tics and the problem behaviors were much more common during the winter months. Dr. Tanya Murphy and her colleagues at the University of Florida were able to piggyback onto a study being done as a surveillance against rheumatic fever, and the children received actual throat cultures in the school once a month during the school year to make sure that if they had an asymptomatic strep, they got treated. Dr. Murphy and her colleagues went to the school when it was time for the throat cultures, and they watched the children in line. They asked them to do the Romberg stance to look for choreiform movements, and they found a 1-to-1 correlation between children whose throat culture was subsequently positive and the presence of tics or adventation behaviors. The thing that makes this study so definitive is the fact that the observations were done at the time the throat culture was being obtained. They had no idea if that throat culture would be positive or negative, and they just recorded the symptoms. And it turned out that there was a direct correlation, and that children who had more than one asymptomatic strep during the course of the school year were much more likely to have this behavior. The second line of evidence comes from the fact that treatment of strep infections can reduce the OCD and tic exacerbations. This is a study by Marie Murphy and Mike Piccichero at Rochester, New York, in which they just went into the records of their very large pediatric practice with approximately 3,000 patients and found 12 children over a 3-year period who met criteria for PANDAS. So that tells you the disorder is not common, but it's actually not rare either, because 1 out of 250 over a 3-year period is actually somewhat common as far as neurologic illnesses go. 7 boys and 5 girls presented with neuropsychiatric symptoms. In actual fact, all of them presented with obsessive-compulsive disorder, and interestingly, 3/4 of the children had contamination fears. About half of them had urinary frequency or enuresis, and in fact, those 7 listed there actually presented with symptoms that were thought to be a urinary tract infection. But when the urinary culture was negative, the very smart doctors went ahead and did a throat culture, found out the children had a group A strep pharyngitis, and treated them. Antibiotic treatment of the strep infections reduced symptom severity within 5 to 21 days for 8 of the 12 children. So again, prompt recognition and prompt treatment, particularly of a symptomatic strep infection, can produce symptom reduction. I'm sorry I didn't put it in here, but Tanya Murphy has a new study just out in the Journal of Child and Adolescent Psychopharmacology, or JCAP, that's available online only, but it's just been released online within the past week, documenting that treatment with cefdinir is also quite helpful to children with PANDAS. The third line of evidence was the use of prophylaxis, and this was actually the most important evidence for rheumatic heart disease, was the fact that if a child was put on penicillin prophylaxis and did not have any further strep infections, that they tended to do much better over the long term. We took that model and said that if OCD and tics are sequelae, are the result of a group A strep infection, then if you can prevent the strep, you should be able to prevent the neuropsychiatric symptom exacerbations. We did a double-blind, parallel design study of azithromycin, which had been found to be a very effective prophylactic agent in military recruits, and penicillin at the usual dose of 250 milligrams twice a day. We had done an earlier study in which penicillin had failed, and we think the reason for that was because we used liquid penicillin for kids who couldn't swallow pills, and if you have liquid penicillin, you really can't remember if you've given the morning or the evening dose, and there's no way to check. And because the half-life of PenVK is only 12 hours, if you miss one dose, you're not protected for the next 5 half-lives. And therefore, if you miss the Monday morning dose because the house is a little chaotic getting everybody off to school, the child isn't protected again until Wednesday night, or essentially more than half of the school week. So the penicillin in the first trial, we had 14 of our 35 strep infections actually happened while the children were supposed to be taking penicillin. And we expected it would function the same in this trial. It did not. And in actual fact, we had complete eradication of strep in this group of 22 children. So we compared the year prior to study entry with the year that they were in the trial that had been the design from the beginning, but that has been criticized by the fact that the year before was retrospective ratings. However, it was retrospective ratings done in a blinded fashion, so I believe that the results are fairly definitive, demonstrating that if you prevent strep, you markedly reduce the number of exacerbations within the children, and you also markedly reduce the number of symptomatic months. What you see here is 5 children, 1, 2, 3, 4, 5, who received penicillin on the left, and 5 children who received azithromycin on the right. The red line marks the beginning of the study, and in the year prior to study entry, you can see that most of the months are symptomatic. And if you take that bottom left panel, that's a child who had 3 separate exacerbations during the year prior to entering the study. And you'll notice that just as the children with Sydenham's chorea, it was his 3rd episode, and he did not actually go back to a baseline of 0 in between, or at the end of the trial. In contrast, the top right, the child on azithromycin, that was actually his 1st episode in the year prior to study entry, and he had 1 month where he had a blip, but it was relatively short-lived. Even though it shows a whole month, it was actually only 4 days of symptoms. The final evidence comes from the laboratory, and you'll hear more about the cross-reactive antibodies from Dr. Cunningham, so I'm going to go through those very quickly, and hopefully the video will work to show you the animal model. If it doesn't work now, this afternoon when I speak, I'll use my own computer and I'll show it to you then. The antineuronal antibody story has been as mixed as the clinical story has been. And every time that Dr. Singer publishes a positive paper, he then feels compelled to follow it up with 2 negative papers. The difference in the positive and the negative studies is which patients are used. And in every one of the negative studies, they have used patients identified out of a Tourette's syndrome clinic. And we're going to talk a lot this afternoon about distinguishing Tourette's from Pandas, but it's actually quite simple to do. It's exactly the same as it is for OCD, in which if the onset is extremely abrupt and dramatic and the tics are accompanied by multiple symptoms, it's Pandas. If it's slow and you have an eye blink tic or a shoulder shrug, and then over the course of a year you meet criteria for Tourette's, that's not Pandas. Well, the CSF showed distinctive differences, and the one thing that I want to remind you of, because I don't know if Dr. Cunningham will speak to this, is the fact that at the NIMH, we had the opportunity to obtain blood and CSF from children who had non-Pandas OCD, and they are just as negative as the healthy controls. So it's extraordinarily important to identify the patients correctly, because if you don't have Pandas, you don't have these antineuronal antibodies present in your cerebrospinal fluid. If you do have Pandas, you have a great chance of having a titer that's very high during acute illness, shown there in the plain red bar, and lower during convalescence, shown in the hash-marked bar. I'll let Dr. Cunningham talk about the anti-dopamine D2 and the kinase activity. And I'll just try, no, it looks like it's not going to come up. So this afternoon, I'll show you the video of the dancing mouse, or the jumping mouse. But you'll have to believe me at this point that when you put our children's antibodies into a mouse model, they demonstrate behaviors that are remarkably similar to our poor children who cannot sleep, who are hyperactive, and have compulsive reactivity. And most importantly, was a study done in Israel documenting that actually if you give strep to a group of mice, actually rats, forgive me, and that's very hard to do. You have to hang the strep up next to the nasal lymphoid tissue to get them to react to the strep. Then the serum from those mice was transferred into another group of rodents, and those second group of rodents produced the same kinds of behaviors. So it wasn't something to do with human antigens within these mice. It was actually mouse-to-mouse transfer was effective in producing disease. The final area of the Pandas model then gets down to what's going on in the brain. What is happening in these children? We think that the evidence is fairly convincing now that group A strep is triggering this, probably through molecular mimicry, but then what happens? Strep is very common. Up to 75% of children will have a strep throat infection during the grade school year, and yet pandas is relatively uncommon. What is that difference? Well, it may have to do with the same models that we use in autoimmune encephalitis, and that is just as we've heard. You have to have the wrong bug in the wrong child giving rise to this pathologic process. You also have to have some way for the antibodies to cross the blood-brain barrier and get into the brain. It's supposed to be a protected space. There's two ways that can happen. The first one is the fact that the group A strep is very famous for producing exotoxins, poisons that actually open the blood-brain barrier. That's why when kids get a strep pharyngitis, they get a bad headache and fever. The second way it can happen is actually that you're able to carry those across on activated T cells, and our colleagues, Kyle Williams and others at Yale University, are producing evidence documenting that there are T cell abnormalities that could explain this phenomenon. The evidence for autoimmune encephalitis, or an autoimmune process in pandas, is threefold. There's the local. We've talked some about the cross-reactive antibodies, and I know Dr. Cunningham will do a much better job than I in helping you understand those. Regional. Most of the evidence, pathologic evidence, is from Sydenham, Korea, because those patients died from their heart disease, and they went through autopsy that documented specific inflammation within the caudate and the putamen. In our patients, we had to use MRI, which demonstrated that in children with pandas, they had enlargements of the caudate and the putamen, those two structures we've been talking about all morning, as well as the globus pallidus, in comparison to a group of healthy controls. And just to make sure you get it right, I didn't label it pandas, I'm sorry, it's OCD ticks. But the pink dots represent children with pandas, and the green represent healthy controls. For those of you who can look at the volume, and you can see that the differences are incredibly small, and it's only a group effect, except in one patient. You've already seen this picture this morning. This was a young boy, 14 years old, who had an abrupt, dramatic onset, a severe obsessive checking and repeating rituals, and also symmetry concerns 2 weeks after coming home from soccer camp. Well, the thing that was interesting about being at soccer camp was that 3 of his tent mates had been sent home for strep throat, but he didn't have a sore throat, so he wasn't sent home. We do believe he was exposed to strep because he had a 20% enlargement of the size of the caudate nucleus compared to age sex-matched controls. And following successful treatment with plasmapheresis that took him from 8 to 10 hours a day of symptoms down to complete symptomatic remission, he had normalized the size of his caudate. We spoke earlier about deficits of executive functions, and specifically its response selection shown in the Sydenham, Korea patients, in which you have very big differences from healthy controls and Tourette syndrome without pandas and ADHD in their ability to change their pattern of response from 1, 2, 3, 4 to a 2, 3, 4, 1. And I find it hard to even say that, but it requires simultaneous excitation and inhibition. And so it really does activate those structures involved in prioritization and strategy. I think it's interesting on this slide that everything is laid out here, that the pandas' pathology is quite different than that of garden variety Tourette syndrome or even ADHD, even though tics and ADHD are part of the clinical picture in pandas. The final and probably most definitive piece of evidence was a placebo-controlled trial of immunomodulatory therapy. Before I show you the results of this, I want to tell you that if you use immunomodulatory therapy on non-pandas patients, it does nothing. And the evidence for that came from 5 open-label treatments with plasmapheresis for children with garden variety OCD, in which there was absolutely no benefit, And Hoekstra had done a study of IVIG for Tourette's syndrome and also found absolutely no benefit of IVIG for non-pandas tic disorders. In contrast, in pandas patients, there was a 45% reduction in symptoms after a single course of 2 grams per kilogram of IVIG, or 5 single-volume plasma exchanges. And we're very lucky to have Beth Latimer here this morning. She's going to talk to you about the new Georgetown protocol that actually uses only 3 1.5 volume changes, so you don't have to put in central lines and do some of the rest. But in our trial, we used 5 single-volume exchanges, and we had a reduction on average in symptom severity of 65% at 1 month. In drug treatment trials, we consider it a great and wonderful victory if we get a 25% improvement after 12 weeks. So these findings were remarkable, particularly since some of the children were better before they even left the hospital if they were randomized to the plasmapheresis. And most importantly, with adequate prophylaxis, all of the children maintained those treatment gains or even better at 1-year follow-up, so that when they came back in at 1-year follow-up, all of the children were in the subclinical or completely asymptomatic range. All right, so we don't have. So is pandas autoimmune encephalitis? And I'm going to answer this before I even show you the answers that I put here. And the answer is yes and no. Some pandas is autoimmune encephalitis, and you're going to find that evidence probably about 20 to 25% of cases. But most of it doesn't yet meet the definition unless you take Russell Dale's definition from Australia, in which he now calls it antibasal ganglia antibody autoimmune encephalitis, and then they are the pandas cases. We have extracellular epitopes. The antibodies definitely bind to the cells, and you're going to hear more about that from Dr. Cunningham, but that's what the CAM kinase 2 activation means. It does seem to alter the function of these antigens. You can reverse the effects of the antibodies by removal, and the clinical picture resembles a disruption of the cell type or the region of interest. If we can establish pandas as an autoimmune encephalitis, it not only sort of takes it out of this realm of controversy, but much more importantly, there are well-established treatment protocols. And I think one of the things that at least I struggle with, and I believe my colleagues do as well, is what do we do with the kids who don't respond with complete cures after that first IVIG, plasmapheresis, antibiotics, or steroids? It's the child who remains sick that we're still trying to struggle with treatment. And I believe the AE offers opportunities for that. We can use new and different drugs like rituximab or some of the other therapies. And I think that what I have learned in the past year is that we need to take this much more seriously. So what does it mean for your patients with OCD? History is absolutely key. If the child meets criteria for pandas, then you should make the diagnosis and treat them appropriately. But if they don't fully meet the criteria, then they're just a child with pandas. And I'm so sorry my beautiful grandson is not showing up. But that's who should be there, right there. My grandson's surrounded by pandas, and he's cute as a bug, but he does not have pediatric autoimmune neuropsychiatric disorders associated with strep. Thank you very much.
Well, thank you very much, Dr. Swedo. This was wonderful. Thank you. Really, I really appreciate it. On behalf of the neurologists, I have to say, we do believe in pandas. Never, never we have dreamt of denying the syndrome. So I'm also worried that Professor Falcini thinks that to fall in the hands of neurologists is bad. Because I actually treated a couple of pandas disorders, and they came out fine. So. Given this, I want to go back to the description of the basal ganglia. I happen to be a basal ganglia enthusiast, let's say. And I like to suggest also the treatment for the immunological side, obviously, is the key. But also for the symptoms, we, I do Huntington's disease, so you must know it's really similar in some aspects, not only the sydenham chorea. I've tried xenazine in one patient who was responding well, but responded better when I added xenazine in this patient. Yeah, which is so far the only drug for Huntington's disease, because as you all showed on the basal ganglia circuitry, haloperidol is being suggested, but haloperidol is very dangerous for the brain in the long term. So xenazine is the newer drug, and it puts down the level of dopamine, which is what you want to kill in those kind of disorders, because the basal ganglia are overproducing, overactive to dopamine, which is produced by the substantia nigra. So xenazine in one child that, God forbid, I published, and from then on I was considered an expert, and I'm not, but I have to say, I'd like to propose a treatment that's combined also with xenazine, because it does have some beneficial effects for the symptoms. Thanks.
Thank you very much. I agree 100%, and I appreciate the question because it reminds me that I forgot the most important piece. I wasn't talking so much about treatment, but it is absolutely essential that we remember that children with pandas have OCD, they have tics, they have ADHD, and they will respond to medications that we know. We haven't tried Sensen, so I'm going to go back and study that a bit and see what we can do with that. It would be wonderful. Thank you.
Pregherei. Sono pediatra e neuropsichiatra infantile. Intanto complimenti alla dottoressa Marzia Guarnieri, pediatra.
My name is Marzia Guarnieri. I'd like to ask you, Professor Swedo, well, first of all, I very much agree with you concerning the history. Many symptoms in common with other brain diseases and also with diseases that occur in acute stress conditions. Emotional lability can be recovered 100% after 3 years. A multidisciplinary approach, for example, psychotherapy, analytical psychotherapy, focusing on the issues at the time of diagnosis, could it be helpful, do you think? And could this be used as a procedure?
Thank you for that question. Psychotherapy can have a very helpful role, not typically during the initial onset of the symptoms. In the initial onset, we actually ask the families to see psychiatrists and psychologists to get education and psychological support. This can be an extremely difficult disease for the family because it does come out of the blue in an otherwise healthy children. After the children move into their more chronic phase of illness, we absolutely recommend that they be working with a psychiatrist. We focus much more on cognitive behavior therapy and exposure with response prevention. And the children do extraordinarily well when they are asked to confront their fears and then to inhibit the compulsions. But in doing that, they also need to have a lot of help and work on some of the symptoms. For example, we had a young girl who responded well to treatment with IVIG, but she felt she didn't deserve to eat. And so her eating restrictions were her primary symptom. The IVIG took away 60% of that, but she still couldn't eat. So we had to move ahead with the psychotherapy, as you suggest. So I would say, as you did, multidisciplinary team, pediatric rheumatologist, neurologist, psychiatrist, and because I'm a pediatrician, I believe the pediatricians should be coordinating all this care and remaining helpful to their children during the illness.
My name is Salvatore Sabassa. I'd like to ask you, Professor Swedo, something about therapy. How long For how long is it possible to treat these patients with antibiotics, for example, but also with immune globulins, and when should we do them, and in which phase? At the time of diagnosis, later on, when?
So that's a wonderful, wonderful question, and I think we'll get into a little bit more with Dr. Kovacevic, who will tell us more about the treatment protocol. But the PANS Research Consortium in the United States is developing a protocol that starts with antibiotics for 1 month at treatment dose, and then follow with steroids if possible. And not every child is going to be able to tolerate steroids because of the activation and the potential for manic response. So if you already have a very anxious child, you might skip the steroids. But a 5-day course of steroids, Dr. Kovacevic's protocol, or a month in Dr. Latimer's protocol is the next step. If the child remains symptomatic to the point that they're having impairment, not getting to school, having difficulties for at least 2 to 3 hours a day, then you would consider IVIG. We have only used 1 course with a repeat if necessary after 6 weeks. So if you've gotten at least a 30, 40, 50% reduction in symptoms from the first course of IVIG, then we just wait, because they will continue to improve. For life-threatening, severe symptoms, the child will not eat, they will not drink, they're impulsive and suicidal, so they're trying to jump out of a car or otherwise hurt themselves. I think we should move directly to plasmapheresis, and it's either 5 single volume or 3 1.5 volume. You could do that as soon as the child is diagnosed, but they have a very good chance of improving spontaneously within that first month. And the final piece is, as we talked about, the use of palliative psychotherapeutic medications during this entire period, cognitive behavior therapy, and prophylactic antibiotics.
How long?
Till they're 21.
How many?
I like to use them till they're 21, and my children, they try to go off during high school, and that's okay, because they get stubborn. But we use oral, we don't use shots. And so I think if I had to depend on IM penicillin, I might stop sooner. At least 2 years if they've had to have IVIG, at least 2 years of very intensive prophylaxis. But if you treat it like a form of rheumatic fever, they should be on it until they're 21.
Grazie. Credo che abbia sottolineato l'importanza della terapia antibiotica e della profilassi, perché molti genitori si rifiutano, sono timorosi nella durata della profilassi. Ricordiamoci la
About the length of prophylaxis, but in rheumatic disease it's exactly the same thing. You have to continue, because as you withdraw, at least in my experience, you have an exacerbation with a worsening of the symptoms as compared to the first episode. Thank you. I'm the mother of 2 Pandas children. I'd like to ask you, for children that are doing well in prophylaxis, if there is a relapse but with milder symptoms because of infections, what should we do? Should we try and look for the etiology of these symptoms and treat the cause?
Thank you for that question, and the answer is yes. We would definitely look to see if they had an infection despite the prophylaxis, particularly perianal strep. And it gets missed very often by the rectum, so that's important. But also sinusitis, they may have other infections, they may have mycoplasma, they may have a viral infection. If it's a virus, we can't do anything. If you can find another infection, you would treat that. For a child who's having a moderately severe exacerbation, I would switch to a treatment course of antibiotics. So if he's been on amoxicillin or penicillin prophylaxis, you'd move to a cephalosporin or azithromycin for a month. Then they move back to their prophylaxis. If you find a virus, don't change. You just keep on the prophylactic dose because a virus will not respond to antibiotics. And then the question is whether or not they need a second course of treatment, and the answer is, yeah, they may. And it can work just as well if it's been 6 months or a year or 2 years or 10 years since they had their initial treatment, because you're treating this round, you're not treating the underlying.
Grazie. Un'ultima domanda che credo serva un po' a tutti. Molti ci chiedono se durante la terapia i bambini devono fare la rivaccinazione quando vanno alla scuola secondaria. Ecco, lei ritiene che la vaccinazione sia non solo virale, varicella zoster, ma anche pneumococco, meningococco, può creare uno squilibrio?
You may have a temporary worsening of symptoms after vaccination because it is an immune challenge. On the other hand, if they don't get vaccinated and they get the real disease, it is disaster. We have had children who refused to get the H1N1 influenza vaccine because their parents were worried about it, and then they ended up getting the influenza. Very severe Pandas exacerbation. So we highly recommend that they get their vaccines. We like to give ibuprofen for 3 days before the vaccine, and 3 days after. It's probably witchcraft, but it makes me feel better. I promised to be very fast because this morning it took too long. So I promised to show you the mouse who had gotten pandas by a serum from one of our patients. Sorry. And this is that mouse in his cage. Come on. Come on. There he goes. He does not have a panda's face. But he does repetitive backflips, and he did this all of his waking hours. And you don't notice how abnormal it is unless you look on the left side of that cage and you see a perfectly healthy mouse who's just kind of eating and standing quite still. So that's the normal behavior. I was asked to talk about whether Tourette's syndrome is how you distinguish between Tourette's and pandas. And just as we talked this morning about the big world of OCD and pandas being a small group of it, exact same thing for tic disorders. Tic disorders include motor tics, movements that you can see, and vocal or phonological tics, things that you hear. There's actually no difference except in the psychiatric definition between a motor tic and a vocal tic, because they both are actually repetitive abnormal release of a motor muscle activity. However, it is important to distinguish between motor and vocal tics because it influences whether or not you meet criteria for Tourette's syndrome. Transient tics, as their name implies, don't last very long. Typically they will come, they will last for a month, maybe 2 or 3, an eye blink tic or a shoulder shrug, or maybe the child has a cough or a throat clear or some other minor noise. Chronic tics are those that last for at least 6 months, so that eye blink sets in and becomes chronic and persistent. In Tourette's syndrome, it is a behaviorally defined syndrome in which you have to have at least one motor and at least one vocal tic present for more than a year. And yes, it really is as stupid as on day 364, you have chronic tics, and on day 366, you have Tourette's syndrome. When we hear Tourette, though, we tend to think of the fact that the patients don't just have motor and vocal tics, they also have a tremendous amount of OCD, ADHD, and other problems. So after everything you've heard today, you might think that there actually is a good chance that a child who meets criteria for Tourette's syndrome will have pandas. And that is true, but it's not all of them, and we don't even know that it's the majority of children with Tourette's syndrome who have pandas. The differentiation is exactly the same as it is if you're trying to think about the difference between garden variety, regular OCD, and pandas, and that is that the ticks have to start all of a sudden and all of them at the same time. Frankly, this has been the argument between me and Dr. Roger Curlin for the past 20 years, is he says any tick is acute because it's not there one day and it is there the next. That is true, but it's a little bit like their example of the amplitude. It's quite meaningless because yes, I can tell the difference between an eye blink tick that wasn't there yesterday and is there today, or a child such as you saw from Dr. Falcini, who literally cannot sit still or eat because the ticks are so disturbing. So extremely abrupt onset is the clinical pathognomonic sign for pandas. The second one is actually in association with choreiform movements, and we haven't talked about those yet today. This is a child who has, let's go back. We'll watch the example of chorea. You saw one earlier, but notice that it's proximal, shoulders, trunk. She really cannot stand still. And every time she tries to hold that hand still, the other one just wildly goes away. Any of the videos done at the NIH, the other way you can tell that it's chorea is we almost always have 2 people in the room to make sure the child doesn't fall over. She's trying her hardest. Big movements, didn't miss them. If I would have had it on fast forward, it's even more obvious. And actually, the telltale sign of Sydenham chorea is the failure to sustain tetanic movements. So they get a milkmaid's grip. They also get a snake-like tongue. And you're going to see this child whose face just grimaces up all the time. Those facial grimaces could well be tics if every time she did them, they looked somewhat the same, or if they were coming in little clusters. But the fact that she can't hold her hands level and still, she has trunkal instability, and if you watch her very closely, she can't even keep her eyes shut, because that's one of the ways that she fails to keep her tetanic contractions. Move forward a little bit. Nice contrast between that girl and this one. Here's a young boy. I can't see the tips of his fingers well enough, but I would say that was actual normal. You have a little bit of up and down movements just because it's kind of hard to hold still with your eyes shut and people watching you, but in general, fairly steady. This boy, similarly, except you notice that his hands aren't quite still at the end. If we watch him long enough, especially on that right hand, his fingers go up and then they come back down. One more. Actually, I want to get you one more that has choreiform movements, so let me go forward just a little. Neurologist, what does this boy have? Hemichorea, right? His right side is just, he cannot hold that arm out there still, and on the left side, he's not too bad at all. When it's only on one side, it's easy to make that diagnosis. This boy has classic piano playing movements. See that he holds his head, he's got kind of a grimace on his face because he's working at it so hard, but he just lets his hands drop and then they come back up. But you look at his trunk, absolutely no instability. All right, pandas, acute onset, presence of multiple symptoms presenting at the same time. Oh, why am I going the wrong way? Pans, exactly the same thing. I was so excited to see the data from here in Firenze and from Dr. Latimer and Dr. Kovacevic, I am now more convinced than ever that PANS may not really exist. And that all we have to do is look hard enough, we'll find that inciting strep infection, and then we can treat them and proceed as if it's PANDAS, or they're going to be in the larger group that Dr. Trifoletti talked about with multiple different factors going on. The OCD diagnosis. One of the reasons that Kurlan and his colleagues really failed to make the distinction was because they were doing it in a neurology clinic and they did not take an adequate history. OCD is a disorder of rational irrationality. The kids recognize their symptoms as crazy and they try to hide them as long as they possibly can. You have to use a structured interview. It's extremely reassuring to the children and their parents to see that the Yale-Brown Obsessive Compulsive Symptom Checklist has put every possible symptom that they could have on there. And particularly if they have those symptoms that are so embarrassing, like sexual thoughts or violent thoughts or other things that they just can't actually accept could be coming into their head. The parents should be able to report on compulsions, but they don't know what's going on in terms of obsessions. The compulsions might take the form of reassurance seeking. Mommy, did I really do that okay? Mommy, did I hurt that boy by accident? Is the sky really blue? Some of the most bizarre questions, and the parents have to answer them exactly right over and over and over again. Meltdowns if they're hurried. This is just sort of a clinical expertise phenomenon, and what you actually have is a child who has to complete all of their internal rituals, and if you interrupt them, they get extremely upset because it makes them so anxious. The bottom line is, if you don't ask the child specifically about obsessive compulsive symptoms, they will not tell. And you saw the delay in diagnosis between onset of PANDAS symptoms and appropriate diagnosis. It's even worse for garden variety OCD. Adults in therapy had an average duration of 10 years between the starting of treatment and the accurate diagnosis of OCD because they were so afraid to tell their therapist their symptoms. So if you don't ask, they won't tell. Differential diagnosis, I'm going to be done in 1 minute because we've already talked about all of these things. If it's not PANDAS, it's probably regular Tourette's or tic disorder. That doesn't mean it's not a brain-based disorder. It's exactly the same. It just means you need to look harder for what the cause is. Autoimmune encephalitis absolutely has to be considered, and I gave you some hints this morning, but I urge you to turn to the Autoimmune Encephalitis Alliance in the United States, or there's a British group that has a beautiful exposition, and the AE Alliance, of which we are now members, is working on treatment guidelines for autoimmune encephalitis. And then finally, we can't forget that just like Sydenham chorea, PANDAS and PANS are diagnoses of exclusion. It's actually spelled out in the criteria for PANS that you have to make sure this patient doesn't have lupus, that they don't have an infectious process or a toxin or a metabolic disorder. So how do you distinguish the disorders? I told you I'd find the picture of my grandson, and I didn't. History, history, history. A child with PANDAS has to meet these criteria. If they don't, they're just as cute as little Paul is, and they're a child with little PANDAS instead of big ones. Diagnostic confirmation through laboratory tests, some of the ancillary tests, but as you've just heard, the chances of having a positive MRI, EEG, or polysomnography is less than the chance of having a negative one. At least 3/4 of the studies are negative, so finding nothing on your MRI is not contraindication to PANDAS diagnosis. Treatment. The treatment of tics in PANDAS is the same as if you didn't think the child had PANDAS, and that is standard therapies, a variety of medications, habit reversal if you want to do behavioral treatments, immunomodulatory therapy. And parents, now I'm going to talk to you for a minute because your clinicians already know this. Tics don't hurt your child. And if they're young enough, they're in that kindergarten to 2nd and 3rd grade, they're not even going to get teased about them in school. They bother you much more than they bother the child. If that is true, there's absolutely no need to treat them. You only treat the tics at the point that the tics are interfering, as you saw in that video, or they're causing the child distress. So please, 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 if you want to write me, and I'll tell it to you again. I know that it's troublesome to watch your child tic, but it doesn't cause them long-term harm. All right, well, we couldn't show you how the symptoms improve except with numbers, so I thought I'd show you one of our patients with Sydenham chorea. And this is a girl who had the chorea mole form of chorea, in which she had a great deal of muscle hypotonia and muscle weakness. So the research assistant had to pull her up out of the chair. Every time she tries to take a step, it sets off a chorea movement in her arms. And notice that even her toes are curling every time she tries to take a step. Well, we spent the 2 weeks she was in the hospital for her plasmapheresis trying to get things worked out with physical therapy to send her back home to California from Washington, D.C. And it turned out to be not necessary, because when she left the hospital, 2 weeks after starting therapy, this is how she looked. She was basically cured. She still has one choreatic movement of her right hand, if you noticed it, but you probably didn't even see it. She was able to ambulate, able to feed herself, write, and do all of her normal activities. I'll leave this up, but I'm not going to take any questions unless somebody's really burning with one, because again, we want to try and get back on schedule. Thank you.